ठीक है ना? Because you know these things, when you have a power cut, किधर से आपका echo काम करेगा? किधर से यार आगे पीछे कर रहे हैं बेटा? Slide कैसे? So I was, I've been listening to this AI thing, but reality is, and you see, this is not, this is diverging from this, but I examined for the Royal Colleges, and still the exam is one of the MRCP is considered one of the top all over the world because it relies on these principles you showed. Stethoscope is still the king. ये सलीम साहब आपके साथ बैठे होते अगर बिजली चली जाए तो क्या करेंगे आप को? This is how life is. So I am just going to touch on something which you folks as internal medicine deal with a lot. From our survey, we found out at any single time in any medical unit, 40% of the patients are with liver or GI related problems admitted, cirrhotics, bleeding, ulcers, and mashallah सबकी आपकी practice चलती gas और दिल जलन और इन चीज़ों पे. So that is how things are. यार ये इसको कैसे आगे पीछे कर रहे हैं बेटा? इधर से. So we are going to talk, I'll just briefly talk about this portal hypertension, which we see a lot. I don't think so we'll have time. I think I'm told it's 10 minutes and 5 minutes for question. So the main thing, what the problem is with portal hypertension. And what is a portal hypertension? Is the pressure that increases in the portal vein. So they think if you have, less than 5, that's normal. Once it goes above 5 mm, then it becomes portal hypertension. If it goes about 10, some say 12, then it becomes clinically significant. What increases the portal pressure? आप खांसी मांसी करें, पेट पे जोर करें तो obviously portal pressure ज़्यादा हो जाएगा. But then there are pathological causes, chronic liver disease, right heart ventricular failure, Chiari, portal vein thrombosis. All these things would increase your portal pressure. If you look at this, this is the crux of everything. Sari gadbad jo hai dekhe, I don't know if we can. If you look at it, if there is a problem here, then there's back pressure. And you as a clinician, this area, see more. There are varices down there. हमें तो पठान देखने नहीं देते इस इलाके को, लेकिन ये कि there are rectal varices which, I don't know, can I ask just out of interest, has anybody seen rectal varices? कोई मरीज diagnose किए rectal varices के साथ? नहीं. The reason is, you see, most people, the socio-economic or the social condition and the taboos, don't allow people to talk about these things, but it is a 20-25% significant. So next time my humble request is, when patient comes कि जी इसको वो है, क्या है, बवासीर है, तो हो सकता है उसको rectal varices also. For students, keep this in mind. See, it is part of a body whether they like it or not. So that's something that presents. Now when these things happen, देखें, एक तो मेरी तरह, if you talk starting garble, तो maybe you think hepatic encephalopathy. This you see very often. When the portal pressure increases, males become pregnant. So that's ascites. And this is what we are, as a gastroenterologist, woken up at night, ki ji bleed ho gaya, and this is a gastric varices. And all these problems are manifestation which you see of high portal pressure. Clinically, measuring portal pressure is difficult. These are manifestations and end stage, I would say end stage manifestation. I won't bore you what causes portal pressure. So, देखिए simple सी बात है. Either liver से पहले pre हो गया ना जी. जब रिश्ता बिश्ता जाते हैं उसको आप pre कहते हैं जी. बात फिर जब हो जाए रिश्ता तो वो मसला आ गया. उसके बाद post, उसके बाद जो मसले मसाइल. So that is how pre, post. So आपको बताया portal vein thrombosis. These are beyond liver. Within liver cirrhosis, these things is what you see. This is the whole problem with portal hypertension is flow and resistance. I don't know if you Remember physics, Bartoli principle, अगर पाइप से कोई चीज़ जाए तो अगर वो उसकी पाइप का डायमीटर कम होगा तो उसमें प्रेशर ज़्यादा होगा, and अगर उसको resistance होगी, so you would have resistance. So the more resistance you have, the more pressure, the more flow you have, is self-explanatory. ठीक है जी? अच्छा, now you all know about stages. This is what just one, if you pick up this one thing, देखिए, if you have compensated cirrhosis, mild portal hypertension है, clinically significant है, varices नहीं है, so बंदा जो है ना 10 से 12 साल तक he will be around, that is quite a good survival rate. The chances of him being run over by a rickshaw or a car are more than him dying here. But you see, as soon as he bleeds, देखिए किधर पहुंच गया, कहाँ 12 साल और कहाँ 1 साल. Just look at how much devastation it causes. So the whole game is geared to stop this progression, or stop to नहीं कर सकते, लेकिन slow कर रही है ना. So once you reach this, then the survival goes to 1 to 2 years, and then ultimately once you become decompensated, as you know from your practices, there's hardly much chance left. How do you measure? मैंने आपको बताया कि invasive portal pressure in clinical setting in a non-tertiary care unit, people like us who work in tertiary care units, for even we also for research purposes do this. वो एक लड़का है, आप पता, वो एक प्रोफेसर साहब हैं, सरीन, शिव सरीन, वो सारा दिन बस ये पोर्टल प्रेशर ही मेजर करते हैं और उसको कुछ नहीं आता है. मैंने उसको पिछली बार कहा, वो मुझे इंग्लैंड में मिल, वो मैं कहा यार हम तुम्हें नस्वार देते हैं, तुम खाओ, तुम्हें पोर्टल प्रेशर सारा याद आ जाएगा. तो बट नॉन इन्वेजिवली, as Awan Saab was saying, we have, I should, listening to his talk, I should put clinical examination, because that can tell you, but ultrasound and fibroscan to look at the cirrhotic state of it. This is the logarithm. The pressure आपको पहले भी बताया था. I told you, see, if you are around this region, you're fine. You know from your practice that once you are divulging in this, then this platelet becomes important because they bleed. और फिर हमारी रोज़ी लग जाती है, एंडोस्कोप डालना फिर हम शुरू कर देते हैं. So that is how it progresses. ठीक है जी? And as I said, this is where we want to intervene. Once you identify the patient, you want to put a block here, because I told you the mortality goes sky high. How do you do it? Obviously, what caused the problem has to be dealt with. जो मसला है वो, तो if it is whatever the cause of liver disease is, if it is hepatitis B or C, Awan Saab is with us. We are about to launch a Prime Minister elimination program. हमारा ख्याल ये है, वो आपकी मर्जी है, आपका ख्याल है हमारा दिमाग ठीक है कि नहीं है, लेकिन ये कह रहे हैं कि जी 2030 तक, 2030 तक we will eliminate hepatitis from Pakistan. We are trying to replicate Egyptian model. I don't know if you've followed Egypt. Egypt has had cirrhosis, a very huge number of cirrhosis. And the reason they had cirrhosis, मैं आपको बता दें तो, we are sorry divulging, is they had schistosomiasis. उन्होंने ऐसे किया ना 60s में कि जी बच्चों को स्कूल में लाइन कर दिया और वो एंटीमनी का इंजेक्शन 50 सीसी में लेके हर एक बच्चे को 2-2 सीसी लाइन में लगाते थे. So then they all got cirrhosis, B and C spread. So we in Pakistan think that our prevalence is about 10%. So as we speak, अभी तो जब हम हॉल में आए तो हमारी आबादी 250 मिलियन थी, जब बाहर जाएंगे शायद 260 हो जाए, the way we are progressing. But we think 140 million, because below 12 we don't. So we are going, so that is going to be the best. So that is basically based on antiviral drug. As you know, Hep C drugs have become like chocolates. They are very cheap in Pakistan. ये तो बीकाराम साहब के इलाके में अगर कुछ हो तो हमारे इलाके में तो नहीं है. और weight loss यहाँ कराची में जो मालदार लोग हैं उनके. So the general therapy which concerns you is this business, beta blockers, जो आप सुबह शाम use करते. And that is because this is what you want to prevent. If you can, with pharmacologically prevent this, so you don't need people like me or the gastroenterologist like Aftab to intervene here. This is endoscopic variceal ligation. And this is how they look like. And it comes to the same point as See, the more you have, this is variceal hemorrhage. Rate of variceal hemorrhage increases. And once you have it, देखिए 60% तो ये आपको बता रहे हैं ना. This is if they don't have any other comorbidities. So in clinical practice, you will lose 80% of your patients when they start bleeding. ठीक है जी? And how do you prevent it? So beta blockers, traditionally non-selective थे, ये proper, अभी you've all used carvedilol, and the reason is of this. मैंने आपको बताया, it's all to do with flow and resistance. So if you reduce the heart rate, the cardiac output would be less. When the cardiac output is less, there will be less splenic flow. The non-selective have beta blockade, so it causes vasoconstriction, and they, especially carvedilol has alpha blockade, so it will cause less resistance inside the liver parenchyma, and that is how you do it. This just shows you that if you reduce the portal pressure, the chances of bleed are less. ठीक है जी? And this confirms that carvedilol, because it's more cardioselective, and because of these studies, this has become the recommendation now as a first line for first variceal hemorrhage. Primary and secondary is what they're talking about. And this just shows that all-cause mortality is still as good. देखिए, this, we as gastroenterologists are very keen on this. Endoscopic ligation does not alter the pathology of the disease. It just is a mechanical thing. It just stops what the problem is. Doesn't address the underlying, whereas the beta blocker does, even for secondary prophylaxis. And this is how the secondary prophylaxis, there's a study I've quoted, and you could see that those who received carvedilol did well. So it, you know, it is, this is what our Trump colleagues say, and I'll show you the colleague after this. So they're saying that, you know, those who have compensated non-selective, you know from your practice, or I'm sure you do, we start with a lower dose because the problem is bradycardia and hypertension. And in cirrhotics, the last thing you want is to make them hypotensive. Why? Because you don't want the renal flow to reduce. Apart from other problems, if the renal flow reduces, then they go into renal failure also. ठीक है जी? And obviously in tertiary care centers like ours, if you have these facilities, fine. If not, this is what you would do. EASL, our European colleagues, are almost saying the same. You know, non-selective beta blockers are good, and that is what you should use. This is, generally in clinical practice, the best thing is you combine both. You give beta blocker and you do, so combination therapy with endoscope is better. ठीक है सर? सर मैं शाम को बाहर निकला था, तो वहाँ एक पठान था, उसने कहा सर तेरा दोस्त आए हुए अमेरिका से. Can you recognize this gentleman? इसने बीटा ब्लॉकर नहीं लिया, तो ट्रम्प साहब अभी इधर फिर रहे हैं आपके बीच में. ठीक है सर? Thank you very much. If you have any questions, I'll be delighted.